All right, so hi everyone, my name's Natalie. Thank you all for being here. As a friendly reminder, you are able to receive CME credits for being here. I'll paste the form for CME credits in the chat. And today we have Dr. Mohammed Gill. He's an assistant professor of internal medicine at Western University of Health Sciences, and also an internal medicine physician currently practicing hospital medicine in Northern California. Dr. Gill, is there anything you'd like to add?
That's enough.
All right. I'll get you started.
Hello and good morning, everyone. Thank you for being here. Today we are going to spend this hour to discuss guidelines came out of Surviving Sepsis campaign, and we all are pretty familiar what sepsis is and what it entails, and the major one of the major reasons for mortality, and comprise about 60% of our patients that come and get admitted to the hospital. Surviving Sepsis campaign, it's what the title is given because in 2002, the European International Society, it's called European Society of Intensive Care Medicine. They held a meeting in Barcelona in about 2002, and they have decided to come up with certain guidelines. And the idea is how to catch early signs of sepsis before it gets to severe sepsis and organ dysfunction. And as we know, when the organ dysfunction occurs, the mortality rate goes up. So let's get started. Please go to the next slide. So I decided that we will start a discussion with case studies. These are real cases, and I have been seeing the past 12 years as a hospitalist, working in the ICU. And one case I stole from another physician. So let's see. The first case is 82-year-old female. She arrives in the emergency room April 9 with complaint of worsening cough for a month. That's her chief complaint. She had past medical history of asthma and psoriasis. When we reviewed the symptoms, she had decreased appetite, weight loss, dizziness, shortness of breath, and jaundice. On examination, pulse was 90, blood pressure 127 over 38, temperature 36, respiratory rate 16. Laboratory data showed creatinine of 2, white count was 15,000. Chest X-ray was inconclusive for infiltrates. BNP was 63, and platelets were 450. She was admitted to MedSurg initially with the diagnosis of acute kidney disease and acute jaundice. Now, I want you to look back because there are several data points have been indicated during this history. So symptoms of SIRS and any organ damage. Is this early sepsis? Should we check lactate, blood culture, antibiotics? So anytime there is any sign of infection, any sign of possible source of infection leading to the SIRS, our mind should always go to the source of infection, or what we call sepsis. And is it going into a full-blown sepsis or not? We should preemptively start thinking about it. Next slide, please. So our goal, therefore, today, we will be understanding SIRS, sepsis, severe sepsis, septic shock, multiple organ dysfunction. Sort of this is the path it takes from initial introduction of infection. So we will try to understand what surviving sepsis campaign is, and management of sepsis in first 3 to 4 days, which are critical. And then if we have a good hold on the diagnosis and the patient, and we are keeping them alive, the mortality goes down. We will have a few points from the updated sepsis guidelines. As I said, the Surviving Sepsis campaign was initiated in 2002 by European Society of Critical Care Medicine. They call it European Society of Intensive Care Medicine. And they hold their meetings every few years once they receive enough data finding best practices. Next slide, please. Excuse me. So the same patient now was admitted to the hospital. At that point, for the first 3 days, there weren't signs of like inflammatory response syndrome, SIRS. It was questionable. The initial doctor didn't pick it up. Patient was admitted with acute kidney disease, right? But once a patient was to the second floor or to the med surg, that was our second floor, patient blood cultures that were drawn picked up SIRS, and they came negative on day 3rd. So far, patient's stable. The repeat physical exam, GSE, blood pressure, GSE is 10, blood pressure went down, pulse 124, respiratory rate 24, and white cell count is 20,000, temperature 36. At that point, the modified early warning system was used by the nursing staff, and the physician is informed. We will talk about what Muse scoring system is. So once the Muse score was about 4 to 5, I think it was 5 at that time, the physician was called, and the early warning system helped the whole staff to upgrade the patient's care. Patient was transferred to ICU. Now, when all this thing is happening, I noticed, and I want you to pay attention to the time of presentation, that when we notice that the patient is going south, and that's very, very important. Time of presentation doesn't mean here, patient coming to the emergency room, rather when the symptoms or the signs are changing, the situation is changing, the presentation is changing. And that is very critical to pick up. We will talk more about Muse in reference to the guidelines, but in the hospital, the staff picking up early signs using one of the scoring system. There is a News, like National Early Warning System. There is a modified early warning system. When I was reading the article, it has mentioned that it is not necessary to have one over the other. Rather, the emphasis is made that hospital system, inpatient system must have some kind of early warning system, so the change in condition is picked up. So once the time of presentation is achieved, which means that staff or physician or nursing aide has picked up change in condition, and change in condition if we look at this slide at patients' GSC, the glycemic scale, the blood pressure, the pulse, because our staffs are not only providers of the data, but we trained our nurses and nursing aide as clinicians. They also go and look for white cell count. They should also be trained and given some sort of orientation how to look at the patient as a clinical case rather than data gathering. And that's also important in this regard. After the time of presentation is achieved, the nursing staff or the paramedical staff pick up change in condition, inform the physician. There are two steps of immediate action. Code sepsis is called, and sepsis bundle is initiated. And that is also updated or carried forward sepsis guideline from previous recommendations. Next slide, please. The Society of Critical Care Medicine and European Society, they are the one mostly leading the definitions and their practicality. The inflammatory response syndrome can be due to infection and can also be a non-infection cause, and that is something new in the past few years. The once we see the change in condition, there are three points or three quick assessments need to be done: understanding SIRS and identifying the SIRS. Once we have identified, next step is to find the source of infection. So therefore, we would have tools to screen for infection. And the third step is to identify organ dysfunction. Next slide, please. Again, it is very important to identify early so that we can provide goal-directed therapy. And that what that would do is it will prevent the case to go a further severity level of septic shock, because every step is critically important. Early sepsis, we use that in documentation when I'm writing, for example, my notes, and also it's important when it comes to learning, like for student level, when we are even documenting and so forth. There are a few guidelines from Medicare, CMSP as well, if it's sepsis, if it's early sepsis, septic shock. So inflammatory response syndrome due to infection is called early sepsis, because SIRS can be due to low blood pressure for other reasons, for cardiac reasons, for distributive shock, for hypovolemic shock, which not necessarily is due to infection. However, early sepsis, which means SIRS plus source of infection. So after we have the idea what SIRS is and early sepsis, the sepsis definition was given by the Surviving Sepsis Campaign as a dysregulated host response to organ dysfunction due to infection. Early screening system in place leads to significant reduction in mortality due to sepsis, and is exponential rise in mortality with organ dysfunction. And there are different numbers. To organ system dysfunction, the mortality goes 40% and more. Most common complications that occur after sepsis is established is acute respiratory distress syndrome, acute kidney infection, and disseminated intravascular coagulation. This is usually the path that septic shock goes, and it leads to high mortality. Next slide, please. We all pretty much know, most of us, what SIRS is, and it's the syndrome of inflammatory response syndrome, multi-organ body syndrome. And when you have any of these two, we can call it SIRS, the temperature more than 38, respiratory rate, pulse, systolic blood pressure, white cell count. And it is important for us, for physicians, to keep the nursing staff and paramedical staff in our teams to keep them informed. For example, let's say keep eye on the patient, and have the scoring system, and they take vitals, and have a system in place anytime these boxes are checked, so that the code sepsis is called and sepsis is caught early. Next slide, please. I have picked up this common sources of sepsis from another article. And I have also, usually I share this with the staff as well, when the two symptoms, 2 points of SIRS, when meets, the next step is to screen for any source of infection. And as you can see, there are all these different organ systems. The symptoms of infection, the respiratory tract, the urinary tract, and vascular catheter areas, skin examination, and that can be done by staff as well. The goal of my discussion today is mostly for inpatient care of patients, where the first-hand personnel, which are nursing staff, they are present and they spend more time than physicians. So these things should be taught to the staff, so they can pick it up in timely manner. This can be found, this table can be found on UpToDate, where I have copied from, and we can hand it over to nursing staff as well. For example, this patient who had complained of cough, and this is one of the system of respiratory, the one symptom of respiratory system. So once patient is presented, say have fever now, has presented with cough, this is a very simple example that we can easily screen. Even a non-physician, a nursing aide or a nursing staff member can pick it up as early sepsis and initiate code sepsis after discussing with the physician. Next slide, please. Screening criteria and scoring system. These are made as a guideline to help us navigate through the path. And out of those is Muse, a new score. When I was working with Dr. Good in Sonoma Specialty Hospital, we had put in place a Muse scoring system, modified early warning system, and we saw the huge difference from before and after The patients were identified early, were taken care of early. The lots of time, this criteria not necessarily leads to diagnosis of sepsis or shock, but also indicates other disease processes. So even if the infection and septic shock is not present, implicating the scoring system for the screening of patients while having regular rounds every few hours and during inpatient care are helpful anyway. And that's what I found in my practice. There is a sequential organ failure assessment called SOFA. It's also one of the screening tool used very commonly. QSOFA is also a very shorter form of SOFA, but it is actually recommended against in 2021 survivors sepsis campaign. Ultimate goal is performance system in place, not specific criteria or component of scoring system. As I mentioned earlier, the goal is to identify early source of sepsis or source of infection leading to sepsis and septic shock. So that goal, the specific target therapy can be initiated. Next slide, please. Modified early warning system or national early warning system, usually used by nursing. Respiratory rate, oxygen saturation, systolic blood pressure, pulse rate, level of consciousness or new confusion, and temperature. These 6 points are included. And you can look into all of these, and they all lead to one of the major organ system, the respiratory system, the cardiovascular system, the central nervous system, and temperature, fever, and inflammatory response syndrome. Next slide, please. QSOFA, I'm mentioning this because Surviving Sepsis campaign in 2021 has specifically talked about it. There were data that QSOFA had been used at a larger scale in multiple institutions, so they came up with numbers after random controlled trials and meta-analysis of those patients. They found that the quick sequential organ system assessment was not a good system. It was missing good data. It was the early sepsis was not caught because it only included respiratory rate, augmentation, and systolic blood pressure. Next slide. And before next slide, I want to mention that elderly patients, if we all know, lots of times their sympathetic and parasympathetic system, their cardiovascular system response to septic shock is not as a textbook as usually in our younger adult patients. The sequential organ failure assessment has 6 organ systems, has 5 points each, and if there are 15 points or more, the mortality dramatically goes to 90% or more. Widely used, very comprehensive. When the partial pressure of oxygen is measured, that gives us the status of respiratory membrane, the capacity of lungs to ventilate. Excuse me. There's an error. It's actually PO2 over FiO2 ratio. So PO2 FiO2 ratio gives us ability of lung to exchange oxygen. It's the ratio that respiratory membrane gives us numbers, the partial pressure of oxygen in alveoli and the presence of partial pressure of oxygen in the blood versus oxygen present in alveoli, gives us the idea how thick is the function is the respiratory membrane. So more than 400, 300 to 400, 200 to 399. And these numbers are used also to identify mild, moderate, and severe respiratory failure, the platelet counts, and initially, we all know platelet counts usually go up, but when they are dropping, start to drop, it should be taken as a sign of worsening sepsis. Liver function, bilirubin level, cardiovascular system, mean arterial pressure. We by now know when in medical school we are taught how mean arterial pressure is significant, identifying the vascularity and the delivery of oxygen, and leads to development of organ system dysfunction in sepsis and septic shock. Use of dopamine or artificial way of improving blood pressure, also one of the point. Next is the central nervous system evaluation. Glasgow Coma scale is used, 5 different values. Same goes for kidney dysfunction. Usually scoring performed at 0 or as we mentioned before, a time of presentation, that's our 0.0, 24 hours, and then every 48 hours. And study shows if we keep the patient alive 4 to 5 days and we consistently and religiously use this criteria and keep patient under critical care monitoring, data shows that significant improvement and reduction in mortality. Next step, next slide, please. Sepsis is a, let's go over the definition wise. I felt that we should discuss the definition because during the hospital rounds, writing of notes and getting goal-directed therapy, a lot of time we come across finding exact diagnosis or the how shall we call it? Is it really sepsis? Is it septic shock? So I felt worthwhile mentioning that. This is almost a daily discussion for me when I'm rounding. Sepsis is a dysregulated host response to infection and organ dysfunction as well. So source of infection, and when host has a dysregulated response in terms of fever, abnormal pulse, abnormal blood pressure, abnormal respiratory rate. These are all dysregulated host responses. Once we determine there is dysregulated host response, there is SIRS. We use sequential organ function assessment score, and if it is less than 2, it is positive. Then we do an infection screen, and if it's more than 10, it's usually high mortality and leads to severe sepsis. Basically, if if SOFA's criteria has more than 10 point, and the severe sepsis can be labeled as diagnosis. Usually severe sepsis is also with 2 organ dysfunctions. So septic shock, when the blood pressure drops and host or body is not able to keep the blood pressure, need of vasopressors and fluid resuscitation is needed, or if it's failed, when severe sepsis is diagnosed, the mortality goes more than 40%. Next slide, please. I think it's frozen. Natalie, can we go to the next slide?
Yes, is it not the 2021 sepsis guidelines? Is it showing?
Yeah, I think it's frozen on my side. Apologize.
No worries.
Yeah, I see it now. Okay,
Okay, good.
thank you. All right, it's time. Let's review sepsis guidelines from 2021. What they have, the old guidelines carried upon, and we will go back to our we mentioned and see what we've done and what we should have done and can do going forward after we apply these new guidelines. There's best practice versus new recommendations. We always said best practice previously. Now there are new recommendations. There are weak recommendations. The system was so far, and these guidelines are usually from different institutions, data analysis, meta-analysis, and the Surviving Sepsis campaign came up with. So we will also, for example, see all the different steps of treatment during the patient hospital stay. And let's start with the number one is the SOFA criteria or the criteria used. Okay, so that's the first guideline, point of the guidelines, and what kind of system when inpatient hospital stay we prefer to use. The Surviving Sepsis guidelines recommended that SOFA or MUSE or new system or SIRS performance system must be used. Idea is not to have one or the other, or but use the components of this scoring system in any way suits the hospital system. QSOFA is recommended against. The serial lactate level previously in previous guidelines and best practice that we do, first hour we do always pick up lactate level. Patient comes to the emergency room, first hour we have this practice of using antibiotic, getting lactate level, and a lot of times procalcitonin level. It has just become a habit, and also the hospital policy coming from sepsis guidelines. But in 2021 guidelines, the serial lactate level has a weak recommendation. Doesn't mean that we don't use it, but they don't think that it is a must be used data. The fluid bolus is also, that was part of the sepsis bundle. And personally practicing, even today, I have reservations giving the fluid boluses to the nursing staff. Um, let them use fluid boluses from sepsis bundle on my patients because of several reasons. One is, if, for example, if patient has CHF in the ICU, has history of CHF, is in the ICU, has septic shock, patient shows signs of distributed shock as well at the same time. Without MD evaluation or nursing staff giving fluid boluses, leading to fluid overload a lot of times. And we had to intubate the patient. This is one of very small example scenarios. The New York guidelines has a weak recommendation against it. The target mean arterial blood pressure should be 65. What they were saying again is to not overload the patient. I remember 10 years ago, we were told that more fluid is always better than less fluid. Because during the sepsis, the organ dysfunction and distributed shock leads to less a less supply of blood pressure, less intravascular volume, and that has been continued. And so the target mean arterial blood pressure should be 65 or higher. And we can't achieve with fluid. We will use the vasopressin or vasopressors. I mean, again, rationale is organ perfusion and there were detailed rationale about for having too high mean arterial blood pressure achieved using pressors that could lead to cardiac complications. So what they are saying is the first step is that we should use fluids, and if fluids are not giving us target map, the next step is to use pressors, but pressors should not be used too much to have map going out of control to 95 and therefore we should keep a close number to 65, a number closer to 65. Antibiotics in the first hour, including MRSA, strong recommendation. When we say strong recommendation, I will be repeating that, means that it's recommended strongly to take that step. And next is the critical care monitoring. Next step, please. Next slide, please. There are no recommendations for common viral infections and initiating antiviral in first hour. However, during COVID times like right now, it still falls into the strong recommendation. When I was actually reading sepsis guidelines during COVID pandemic, procalcitonin has been widely used. Some places a little too much. What's procalcitonin? It's a marker. It's an inflammatory marker, and it is associated with bacterial infection. And I usually use when, for example, patient has a cough and all the symptoms of respiratory system. Chest X-ray, for example, in this patient, in this case that we have no infiltrates, but the blood cultures are negative, but I continue to see that there's white counts and patient is coughing. Occasionally there is temperature. Now I have to decide whether is it a viral infection or a bacterial infection. Is there pneumonia that's so subtle that chest X-ray is not picking up? A lot of times patients are already dehydrated. when they present dehydrated, chest X-ray will not show the infiltrates. So these are some situations where procalcitonin is beneficial. Continuous assessment for infection versus non-infectious sources. A lot of times we are fooled with hypotension. Hypotension leads to idea of having maybe is it a septic shock? Of course not. Hypotension is just one symptom, and we have to look at the patient as a whole and determine the reason of low blood pressure. And therefore, when the SOFA criteria is really important, that encompass all the other systems and give us the idea, a better idea, clear picture, what exactly is going on. Dynamic fluid resuscitation monitoring, that's like Swan-Ganz catheter, and the arterial line monitoring, these monitoring system, or using like Cheetah, that currently I use that still in the hospital system, where we have SVO2 monitoring, giving fluid bolus, SVO2 monitoring. Most critical care physicians know this SVO, the Cheetah system in the ICU to see if patient responds to fluid or not. These are very helpful. These are good steps. However, guideline says gives a weak recommendation. They're focused more on actual fluid resuscitation, assessment of vitals, and administration of fluid and antibiotics. 2 antimicrobial agents for gram-negative sepsis, hospital-acquired infections, and beta-lactam and the beta-lactamase microbial infections, ventilator-dependent infections. A lot of times have the bacteria leads to fatal infection and septic shock. So 2 different agents to cover gram-negative infection. Well, there's a weak recommendation about it. So when I was reading about this specific recommendation, it was mentioned that the physician or the team in the hospital, they actually should look into the whole case scenario, because it could very well be a simple infection of it just streptococcal infection leading to septic shock, and can be treated with Rocephin, let's say, not requiring the Zosyn and combining with vancomycin. That is kind of common regimen we use. So the idea is to give antibiotic in the first hour, a broad spectrum antibiotic. That is the strong recommendation, and choosing a specific agent, that is the strong recommendation. Norepinephrine versus dopamine and vasopressors, and oxygen saturation, use of oxygen saturation monitoring, no mortality benefit. Corticosteroid use recommended with the weak recommendation. Restricted use of transfusion. That's meta-analysis found that use of blood transfusion and blood products led to a lot more complications. So the benefits were using over less use of transfusion were not significant. So therefore, it's strongly advised that we restrict the use of blood products. VTE prophylaxis, always recommended. Enteral nutrition versus parenteral or hyperalimentation recommended. Or and when patient has septic shock, it is also worthwhile to initiate preemptively palliative care with family meetings, discharge planning. Also recommended in the previous sepsis guidelines as best practice. Next slide, please. ARDS and intubation. I'll quickly go over these steps of management. The mode of ventilation, for example, the BiPAP versus invasive intubation. The ARDS and ventilator care has a strong recommendation. The partial pressure of oxygen versus PaO2, FiO2 ratio, severity of disease is determined. Patient with ventilator is usually in mild to moderate or severe respiratory failure. I thought it's worthwhile to go over quickly, especially in the past couple of years when we were seeing patients coming with COVID and respiratory failure. The sepsis guideline does not dictate us mode of ventilation, rather they do recommend using some sort of artificial respiratory support when ARDS is established, number one. Number two, when there is moderate to severe respiratory failure. And we determine mild, moderate, and severe respiratory failure based on PaO2, FiO2 ratio and the severity of disease. Actually, the 2021 guideline also went over details of management, ventilator management. Also recommended a lower tidal volume, PEEP and plateau pressure monitoring during ARDS. We all know using low tidal volume, prone positioning, and monitoring plateau pressure not to exceed 30. That's sort of our major points that monitor in patient in ARDS on ventilator. Next slide. I wanted to share the slide of antibiotics. Right, and these are the different antibiotics used in case of pneumonia and bacteremia, intra-abdominal infection, and urinary tract infection for time duration. The recommendation came in these guidelines to use the shortest duration of antibiotic. It was recommended to choose less days than rather than long-term use of antibiotics, which we have currently in place in our most hospital systems, where we determine the duration of antibiotics and stop them early when they are not needed. In case of pneumonia, different RCT reviewed data was extracted, and at one place, the patient's outcome was not different when antibiotic was used for 5 days or 7 days for pneumonia. But again, physicians and medical team can decide based on other infections present at the same time or patient's response. But in general, it is recommended that we choose shorter duration of antibiotic and limited use of antibiotics. There are other examples. For example, bacteremia, the shorter and longer duration of antibiotic. There weren't much difference in intra-abdominal infection, urinary tract infection, and so forth. Next slide, please. So let's go back to our patient. The patient has, upon arrival, has probably had early sepsis. On day 4, I think I should have had the other numbers. Probably you all have forgotten our patient. The patient was, remind you that patient, it was 83. The patient had cough, came with AKI, means creatinine was high, and showed signs of, one of the signs of SIRS. And on day 3, patient had low blood pressure and hypotensive, and went to hypotension and organ dysfunction. This, when we calculated the SOFA, it was the score was 7 in this patient with 2 organ dysfunction. What do we do next with severe sepsis? Antibiotics, of course, in first hour, single agent or double agent. We just discussed that. Blood culture must be taken before antibiotics. Highest recommendation, use of fluid. Are you going to take serial lactate? We just went over the recommendations. It's a weak recommendation, but helpful. There is also a series of serial lactate in sepsis bundle, the previous recommendations. Is it helpful? Yeah. Is it absolutely necessary to follow for the diagnosis? Probably not, but again, it's the bedside physician or the team taking care of the patient can decide. Patient should be admitted to ICU, and timing is key. The early diagnosis or time of identification of time of presentation is the key in the whole process. Next slide, please. Natalie, next, please. So how did we do? The nursing protocol management use assessment was performed, doctor was called, code sepsis was initiated, and we took blood cultures. Again, when hypotension occurred, antibiotics had been initiated. As far as lactate, it's important to know that just only the lactate rising does not mean septic shock. There are several other reasons for lactate to go up. For example, oral hypoglycemics and the renal tubular acidosis and so forth. Next slide, please. Very quickly, I think I have time to go over case 2. 58-year-old male with gradual onset of altered mental system per caregiver, past medical history, metastatic breast carcinoma, ascites, obstructive jaundice. Per EMS, upon up the patient from her home, blood pressure was 60/70, respiratory rate 20, blood glucose 124. The patient received DFE in the field, loss glucose scale was 10. Let's use our knowledge of SIRS and take the take recommendation of the guidelines and follow the system. So there are 2 points: early detection of the whole sepsis, so low blood pressure, the pulse, the Glasgow Coma scale was 10. Organ system, source of infection. Then these just very little data can provide us tremendous detail. And organ system dysfunction, we extract as low GSC, cerebral cardiovascular system with low blood pressure, the respiratory rate. Next slide, please. Upon arrival in the emergency room, the patient had been receiving fluids. Antibiotic was initiated, and the blood cultures were taken, chest x-ray, blood gas, and lactate. For our students and our physician early training, I also would like to mention that skin screening in patient with septic shock is most important. Lines, sites of lines, whether there's erythema, because that could lead to goal-directed therapy and source of infection. Gram-negative sepsis, single, double lesion, depending on the patient's condition. If it's diabetic, if there's fear of Pseudomonas infection, MRSA infection. So at 48 hours, patient is still wheezing altered and has no peripheral edema, oxygen saturation 81%, 6 liters, chest x-ray show bilateral infiltrate. However, blood pressure started to show improvement, and patient was intubated. Next slide. Therefore, ARDS was established, and I want to mention also that the diagnosis of ARDS as reminding us that the acute respiratory distress syndrome, by definition, is the bilateral infiltrates in presence of good cardiac output. Just for students, it's a question actually I've asked in the board exam, and I mentioned that in my rounds a lot of times, that if I ask single most clinical finding for CHF, is peripheral or dependent edema. Patient in ARDS, we do prone positioning, we manage our ventilator setting, keeping tidal volume low, plateau pressure 30, unless thick chest or high pleural pressures, or if it's a huge person. Monitoring the, again, our ventilator settings to find sweet spot, I call, for PEEP, keeping transpulmonary pressure in normal range in order to keep respiratory membrane integrity. Next slide, please. Okay, we are at time. And any questions, discussion, comments, all welcome.
Yeah. Dr. Good,
yeah.
Can you hear me? Do you hear me?
Yeah.
Yeah. You know, that was a very thorough, you worked hard putting that together. I think that your slides were, you know, very covering the topic very well. And I like the way in which you talked about weak recommendation, strong recommendation. The whole problem to me with sepsis is timing, trying to get, as you pointed out, the right diagnosis. And one thing that has really entered the field is ultrasound. Now, we're going to talk about this next week a bit, but when you're with the patient in that first hour, trying to say whether it's pulmonary, whether it's abdominal, whether it's cardiac, whether it's renal, whether it's muscle, in terms of the source of infection, because as you point out, starting those antibiotics right away is probably the most important thing in terms of reducing sepsis mortality, more than anything, in terms of getting the antibiotics going right now within an hour. The fluid is important, but that is not as clear. Depressors, that is not as clear, but those antibiotics. And I think there's a real role for those of us in ICU medicine to begin to use ultrasound to make quick decisions within the 1 hour with the patient, not sending them for a CT, that takes too much time, and so forth. But it's a new tool, and I think Mary Graves is on board, and she's really been donating these ultrasound piece of equipment to us. But it's very important, I think, adding on that for timeliness. Now, your presentation was very thorough, and I thank you very much. You worked hard on that, Mohammed, and thank you.
Thank you very much. Thank you.
Yes, thank you. That was excellent. We do have a couple minutes. I'd like to open it up for questions. If anyone has any questions, I'll also send the link to the CME form again if you'd like to get credit for this presentation. I'll just put that in the chat.
Mohammed, thank you very much.
Okay, thank you. Natalie, how was the audio system? I think my iPad, I was having a little issue with freezing, but was it audible at all?
Yes,
Yes,
it was audible. There were a couple times where your video froze, but I think we could hear it well. I think Dr. Amer has a question. If you'd like to unmute yourself, go for it.
Okay.
Hi, good morning, Dr. Mohammed. I actually have a question regarding hyperbaric oxygen therapy in sepsis. What's your thought about it, and what do you think the percentage of people, especially you saw like during COVID, required that kind of therapy?
What I remember, Dr. Good can throw some light on it, but oxygen, FiO2, let's say FiO2, the delivery of the amount of oxygen is actually prolonged exposure. Let's say prolonged exposure of high amount of oxygen is cytotoxic for body, and especially lung tissues. So we always keep low oxygen FiO2 or enough FiO2 to keep the reasonable PaO2 level. I think hyperbaric oxygen is helpful in chronic wound and tissue healing, as far as my knowledge is concerned. What do you think, Dr. Good?
I don't think it has a role in septic shock in general, unless you had really, necrotizing fasciitis, something you'd want to try. It's very hard to take these people out of the ICU and do this. And it's hard to send them out for a test because they're so prone to have arrests and so on. But in general, hyperbaric isn't really the answer to septic shock.
Okay. Thank you very much, everyone. And thank you, Dr. Good. Thank you.
Thank you, Dr. Gill. Thank you very much.
Thank
Thanks, everybody.
Thank you, Dr. Gill, for your presentation. If anyone would like to make a presentation in the future, I'll put my email in the chat. You can reach out to me. But yeah, everyone have a great rest of your day. Thank you very much, Dr. Gill.
Thank you. Bye. Thanks, Natalie.